Hello everyone, welcome back to Shade Tree Cardiology. I've been getting a couple of requests to do some nuts and bolts videos on transmural MIs or the STEMI, something geared a little more towards the medical student or the paramedic or nursing student. So I came up with the idea of a three-part series. This is part one, and this is called STEMI. What is a STEMI? Okay, so as always, if you have any questions, you can email me at shadetreecardiology@gmail.com. So let's get right into the nuts and bolts of it. So what's the purpose of a 12 lead? We diagnose a STEMI with a 12 lead. The purpose is not just to find a STEMI or rule one out or anything like that. There's a lot of information on a 12 lead. There's a very in-depth picture. So we can see transmural ischemia in many, many ways. The reason that is important to our discussion on STEMI is because most of our ideas of, a giant clot, it needs to be heparinized, it needs to be PCI'd, etc., those don't really apply in the real world. Everything's not just a clot or not a clot. There's a lot of different things out there, and I've done some videos on those in the past with transmural MIs that are demand ischemia, Prinzmetal's angina, Wellens, those types of things. So it's not unlike running diagnostic codes on a card. There's a lot of different things that can contribute to the transmural MI. A left main coronary artery occlusion comes to mind, where you might not see ST elevation anywhere other than AVR. However, there's definitely transmural ischemia, which is what a STEMI really is in that situation. You're just not going to have ST elevation in two contiguous leads all the time with that. So just sort of a way of looking at things. I want you to kind of step outside the box when you think about STEMIs for the rest of this video, and just work with me. I promise it will be worth it. Okay. In addition to that, the 12 lead can give you insight into heart function, pulmonary function, and intracranial pressure, and a lot more than that. So let's get to it. Couple things about the 12 lead. You need to know where everything's at. So this is a really neat reference card from Mercy Hospital. Now, as you can see, lead 1 lateral, lead 2 inferior, lead 3 inferior. I'm not going to read all this out to you. You can just take a look. You need to memorize all of this. Now, while this really looks like it's a jumbled up separate set of pictures of different places in the heart, it's really not. These paths actually trace the 3 main coronary arteries, and that's something I'm going to show you right here. If you look in the lower right hand corner, you can see that 1 and AVL are your circumflex artery. So they correspond to the purple section of the heart right up top. The right coronary artery is in green, and then the entirety of the precordial leads is usually considered to be the left anterior descending. With the exception, some people will state that V5 and V6 is a circumflex artery representation as well. Given the way the leads, the electrodes move around, I can completely agree with that. The one caveat I would put out is, we all know that human beings are not anatomically the same from one person to the next. So my LAD may reach places yours doesn't, and I may be right coronary artery dominant, and you may be left circumflex dominant, and so on and so forth. So given that there are inconsistencies from one patient to the next, I would agree that these 2 leads, V5 and V6, could also be representative of the circumflex. Moving on, this is a very nice color-coded picture of the heart where you can kind of see where things are represented. Feel free to pause and just study on that if you want to. The next thing I want to move into is the reciprocal depression. This is a very hard concept for some people. I would like to try to simplify it for you now. One of the things you'll notice on here is, for example, if you go down to the lateral section, your reciprocal depression is in 2, 3, and AVF. If you look at inferior, it's exactly the opposite. The EKG looks as much through the heart as it does at the heart. This is the reason why a posterior wall MI, so a posterior STEMI, so to speak, looks like an upside down STEMI waveform in leads V1, V2, or V3. The reason is these are looking through the heart, and they're seeing it on the back side of the heart. So I just want you to think of reciprocal depression as happening on the opposite side. Now, because we don't take a full 360-degree picture of the heart, the septal and the anterior sections of the heart don't produce reciprocal depression per se. If you were to take, for example, V3 and V4 and put those completely on the opposite side of the heart when someone was having a posterior wall MI, you would in fact have elevation. If you put them on the patient's back, you would in fact have elevation in those leads at that point. So there's always reciprocal depression technically. It's just that we don't have electrodes that wrap all the way around the heart. And this is why we get into things like 15 leads and 18 leads and stuff like that. Okay, so just to clarify that a little bit. So what is a STEMI? Getting to the point of the video. A STEMI is a transmural MI. It's something you can't afford to miss. Transmural means the full thickness of the myocardium is starving for oxygen and injured. And I can't stress that enough. You have ischemia, and then you have injury, and then you have infarction, and they get worse as they go. Ischemia is just starving for oxygen. Injury is the cells are dying. They are beginning to die. And infarction is dead cells. Dead cardiac cells will not regenerate the way that we like to think that they would. When a large section of the myocardium dies, it will remain dead. It will not heal. This is the reason we have things like 60-minute door to balloon times and 90-minute scene to balloon times and things like that. So the transmural MI is often called a STEMI. This is the term we've chosen to go with. Under normal conditions, it's going to present with elevation in the ST segment. Of course, that's not always the case, and we have imposters and different things, but for now, we're just going to stick to the simple STEMI. So what does a normal QRS look like? We're not going to get into time frames and all the different intervals and things here. The one thing I would like for you to really think about is, look how after the P wave, there's a section where the voltage returns to neutral. This is called the isoelectric line. Then the QRS hits, and there's another section of neutrality, and then the T wave comes up. So when the ST segment is elevated, it means that you have your Q wave, your R wave, and then your S wave doesn't make it all the way down to the isoelectric line before it goes into the T wave. The reason is the potassium channels are malfunctioning at that point. If the potassium channels malfunction and they don't work, the heart cannot go back to a negative charge. Potassium is what keeps our hearts negative. In the human heart, our ST segment becomes elevated because as we become ischemic, the potassium channels do not work correctly, and our heart in that section of it will not return the myocytes, it will not return the cells to a net negative charge. And this is why it is represented with an elevated ST segment. So let's look at a normal waveform again on the left, and then you can see ST elevation on the right. So that's about 1 millimeter. The reason I chose this image is because 1 millimeter is enough. 1 millimeter is plenty. For whatever reason, we have gotten to a point where we like to rate the size of the heart attack or the amount of the ischemia or how bad it was. We like to hang our hat on how many millimeters of elevation there were, and millimeters of elevation does not equal necrosis. It can be just as bad for your patient at 1 millimeter as it can be for 8 millimeters. Let's see here. Another picture of a myocardial infarction. As you can see, this is probably a more common presentation. I know the picture is a little grainy, but the waveform is more, it's more closely related to what we see out in the field. Not everything's beautiful the way it is in the textbook. And again, this is another myocardial infarction picture, just to give you an idea of the different things you might see in different leads when we talk about ST elevation. All right, so again, this is a problem in electricity. We're not able to get back down to the negative charge of the myocytes like we want to. We need blood to make electricity. Without the blood, we get the STEMI. And that's why STEMI is usually so closely related to blockage in our minds. But again, a STEMI could just as easily be not enough blood as it can be a clot, although that is much more rare. More often than not, there's a clot or a vascular occlusion, okay? All right, so let's move forward. So to call it a STEMI, to wake the interventional cardiologist up at 3 a.m., you need ST elevation in 2 or more contiguous leads. What that means is 2 leads that represent the same area of the heart. So 1 in AVL because they represent the left circumflex, or 2, 3 in AVF because they represent the inferior wall, right? Which means you could have it in 2 and 3 or 3 in AVF. Just 2 leads. With the precordial leads, V1 through V6, any 2 of those in a row, V1 and V2, V2 and V3, V3 and V4, V4 and V5, V5 and V6. Any of those is fine. You can't have V1 and V6 and count it. They have to be touching in the precordial section. All right, what it is, this is a way of saying, okay, this entire area of the heart has been impacted. It's very unlikely that you could have an area of the heart that is so very ischemic that the ST segment could be elevated without it having spread into the sections of the heart next to it. So it will be represented in those leads. So this is really just kind of a sieve for keeping those false cath lab activations at bay. All right. That's really all there is in the beginning here for part one of what a STEMI is. If you have questions, you want further clarification, please do watch part two. And as always, you can email me at shadetreecardiology@gmail.com with any of your questions. I enjoy answering them. Make sure you send me a request if there's a certain video you want to see. I really enjoy doing that. Until then, you guys have a great one. Take it easy.